Look, okay, and here we go. Basics of 12 lead 5. I'm tightening it up every time. So let's go through my basics of what I look for on all EKGs. Every single time I go through these basics, I'm going to get shorter and shorter and shorter. And then if anybody doesn't understand what my basics are, I'd recommend watching videos 1, maybe 2, certainly 1, and follow along, look things up on your own, and send me questions. Okay, so step 1, I said get familiar with normal ECG. Normal 12 leads. Look at thousands, millions, quadrillions. Number 2, understand chest / cardiac / pulmonary anatomy and physiology. That means knowing how blood pumps, chambers, vessels, pressures, especially if you're critical care, and waveforms also, especially if you're critical care. This includes coronary arteries in terms of vessels, pulmonary arteries, pulmonary veins, and aorta and the vena cava. I guess when you get into more advanced stuff, that could be affecting thing. You have the nervous system, toxins, metabolic stuff. Yeah, that makes it a little bit more complicated. But this one is focused on electrophysiology. And how this looks on an EKG tracing. So ECG tracing. So we have 12 leads. They are grouped by anatomical area. They have an axis. And then last video, we talked about how that axis starts, so with the electrical conduction system of the heart. So understand in general that the heart has 3 primary functions. Like all the cells are automaticity. They could generate their own impulse. But you have a specialized tract of tissue that specializes, like a highway easy pass lane, in conducting electricity, whereas all the other outlying areas don't conduct electricity as quickly because they're not as specialized. So this is like running on a treadmill with no wind versus running backwards in the snow, uphill both ways in the mud. Know what I mean? So the farther away you venture from specialized conductive tissue, the more inefficient, i.e. time-consuming, you become. And what is time on a 12-lead? Time equals the x-axis. Amplitude, or basically electricity, equals the y-axis. Okay. Sorry, still getting over a cold. In terms of axis, we also have this R-wave progression. What I use to reference these are Einthoven's triangle and Wilson's central terminal. Oh yeah, that's leads 1, 2, 3, AVF, AVL, AVR, and V1, V2, V3, V4, V5, V6. Okay. But we also have another concept which I introduced last video. Instead of this electrical flow top to bottom and repolarization bottom to top, we have this other concept called electrical diffusion, where the impulses spread from one cell to another, inward to outward, or endocardial to epicardial, inside of the heart to the outside of the heart. There's also reperfusion or repolarization, which, not reperfusion, but repolarization, which goes from the epicardium to the endocardium. This concept's important. Why is it important? Let's go to paint. If electricity goes like this towards a positive lead, it's a positive deflection on the EKG. If it goes away from the positive lead toward a negative lead, it is, actually, this is a positive lead. So that would be positive. But if you're looking at lead 2 and it's going away from a positive lead, that is a negative impulse compared to the isoelectric line, right? Similarly, if it goes from, let's say that's the outside, let's say that's the inside. So here is blood, ka-chow. This is the endocardium and the epicardium. Let's draw those blue. Endocardium, epicardium. If electricity is going from here to here, positive. From here to here, negative. Now let's do a little math where it's like a double negative, right? If we are going from a negative towards a positive lead, that is a positive deflection on the EKG. If we then repolarize from a positive to negative lead towards a negative, that is a negative. But repolarization is not this QRS complex. That's represented by the T wave. So the T wave would be inverted, but it's not. Because when we depolarize, we go from the inside of the heart to the outside. And when we repolarize, we go from the outside of the heart towards the inside, which means that this is a mirror image of positive to negative. This would be like two runners running in opposite directions. So one is going this way and one is going this way. But this one is running backwards. So when a camera captures a picture of both of them, they're both facing this way. Does that make sense? So what would be a negative inflection, because you're going from a positive towards a negative lead, you are also going from the outside of the heart towards the inside of the heart, which is the opposite of the z-axis, I suppose, because the heart is three-dimensional, right? So that turns this into a positive. That's why the majority of the leads on an EKG have a positive T wave. Okay, moving on. I think my last video, this timer said like 29 minutes and it was actually an hour. So I think for the most part, this is kind of what it's all about right here. And then, oh, no, we have all the intervals, waves, complexes. So you have the P wave, PR segment, QRS, QT, ST segment, T wave, QT segment, sometimes a U wave, and then we have this T wave until the P wave, which in the absence of wandering baseline or artifact, this represents the isoelectric line. Then we have what looks normal. Well, look up normal 12 lead. That looks normal. And then we have what looks abnormal. We have the morphology. Is something normally round that is now triangular or peaked or tinted? Expanding on this, is something normally smooth, but now it's bumpy or notched? Is something at the isoelectric line, but now it's elevated or depressed? Is a wave inverted, flat, or absent? Is it wide, narrow, or just plain old bizarre looking? So these are things you start to build. With repetition, you start to build familiarization with what's normal, and then you start to pay attention to more and more of what is not normal. That's it. That's the key. I don't really go in any particular order, but I do some basic stuff first. I look at the rate, Oh yeah, and the rate. We forgot about the rate. I look at the rate, the morphology, the intervals. Are there all of the complexes that are supposed to be there? Do they appear normal? What is the R wave progression and the access? And then I dive into it. So let's do that. Oops, that's my last video I was watching. Okay, this is where we left off. I promise, I am being honest. I see, hear that? That's my piece of paper, my preferred status certificate that offered me funds up to $40,000 from some bank that I don't want to do business with. Hear that? That's me covering up the screen. I do that on all of my test questions. I cover up the screen, I cover up the answers. If I can come up with the answer in my head, and then that answer shows up on the possibilities of answers, then it is almost 100% certainly correct. You know, at least in a test taking where there's time limitations, if I come up with the answer, and then that's one of the possible choices, I choose it and I freaking move on, baby. Yes, I do. So this makes it challenging because you don't have any clinical context. Sometimes going to the patient, what you get toned for, if they tell you it's dialysis, if it tells you something about their past medical history, if it tells you that they have had a CABG in the past, like that paints more of a picture. Oh, painting a picture. That's right. I have this thing that I call like the flashlight analogy. And it has to do analogy. And it has to do with like where is the camera or lens pointing on an ECG? Sorry, switch gears here. If you have a flashlight pointing this way and you are looking at this lead, you are not seeing what's in the flashlight. If you want to analyze this lead, but there's some sort of axis deviation that is bending your flashlight this way, you are no longer looking in this lead. Here we have the principle of proportionality. If your lead normally looks like this, and then you point the flashlight away from it, but it still sees some of it, this lead might look like this now, right? If you have marginal, let's say 0.8 millimeters of elevation, because 1.0 is the magic number in lead 2. If you then assume that you have axis deviation pointing the camera this way, and then you imagine that you pointed the camera back this way, wouldn't you think that 0.8 would then turn into something more? Because like if you see 0.8 when the camera is not even pointed towards it, imagine what you would see if the camera is pointed towards it. So this is what's important about proportionality. If your QRS complex is itty bitty and you have like 0.7 of elevation, that might be significant. Versus if you have a huge QRS complex, you might need like 6 millimeters of elevation to call it a STEMI. There's a principle called the Sgarbossa that you can apply to stuff like that. So I apply the principle of proportionality to everything. How big are each complexes compared to the remainder of its beat, right? If the P wave is big, then do you have atrial enlargement or some sort of atrial abnormality? If the T wave is broad and bulky, do you have a STEMI equivalent? If the T wave is peaked and pointed, do you have a potassium disturbance or electrolyte abnormality? If the QT is all of a sudden really short, oops, I meant to do this. Do you have an electrolyte abnormality? If the PR invoke gets really short or really long, do you have an electrolyte abnormality or something wrong with the AV node or the SA node? Yep, proportionality. Okay, continuing. Yeah, so that's my analogy. Okay, let's get into it. So we're going to cover stuff up and we're going to zoom in and try to diagnose some 12 leads. without looking at the cues or the possibility or the possible answers. So this is where we had last time. What did we say on this one? We didn't say this. I got it wrong. I thought it was neurogenic. Where's my backup answer? I mean, if you could get one of the two answers, like without really looking at what the answers are, that's pretty dang good. I'd pat myself on the back, especially since we're doing the 4-star ones at the attending physician level. We're like basically cardiologists together. All right, let's do this. 1, 2, 3, 4. That's 4. Sorry, I had to uncover it. Okay. Ooh, wait. I feel like we did this one. I think we did this one. Yeah, we definitely did. Which one is it not? Yeah, we did this. Okay, sorry. Let me cover it up again. What did we stop at? I think we did this one too. Was this the dextrocardia? Yeah. Ah, cheapers, wasting time. Okay, let's keep going. 2 stars, 3 stars, 4 stars. Huh. I think we did this one too. Maybe not. Okay, so it's possible that I'm going to mess this one up and cheat because I feel like we did this one. I feel like I remember the 2 PVCs. I got to look. Exertional dyspnea, waiting surgery. Oh yeah, this was the rheumatic one, right? Yep. Okay. I think this is where we stopped. Jeepers. 4 stars. Oh, we definitely did this too. This was a STEMI. Yep. Okay. 2 stars, 4 stars. I don't think we did. I think this one is. No, we did this. Man, how many did we get done yesterday? Wasn't this hyperkalemia? With somebody who had like kidney disease? Yeah. Okay. This is 2 stars. Next. 3, 4. Okay. I don't think we've done this. It does not look familiar. And I don't have any of the clinical context. Let's see. Have we done this? Well, let's get into it. And as I talk more, if it sounds familiar, then maybe we're repeating stuff. Okay, right away, it does not look normal. Why? These are really, really tall. They should not be that tall. These are really tall too. Jeepers, everything's tall. Huge. Oh, and a really tall R wave in lead V1. Maybe this person has right and left ventricular hypertrophy. Okay, the rate looks okay. 1, 2, 3, maybe like 80 beats a minute, 80 to 75 to 80, 75-ish. The QRS complexes are narrow. The P waves are a little small, actually, given how big the amplitude of the QRS complexes are. The T waves, they honestly look okay. Inverted T waves in V1 is a normal variant. There's a little bit of notching there. I don't know what that indicates. When you have right-sided heart failure and left-sided heart failure, or ventricular hypertrophy rather, you can get one side of the ventricle, I'm sorry, of the septum. Imagine this. Imagine this side of the septum is huge. So it takes more time and more energy to depolarize it, right? So if one part of your ventricle, as is seen from V1, which is really close to it, that's why these leads are really good for diagnosing bundle branch blocks. If one side is huge or both sides are huge, then you have delayed septal activation as it gets through all that tissue, right? Causing this like notched looking
Oops, that should have been inverted. Notched looking QRS complex. Anyways, yep, that's what that looks like to me. And that's why it's probably isolated in here. But our wave progression is not bad. Yeah, so the heart is definitely moving electricity from here to there. Is there axis deviation? Not really. Nope. Yeah, so the electricity is actually moving kind of where it's supposed to. It just seems like both sides of the heart are probably big. Okie dokie. There is this like slurring of the S wave. Or sorry, slurring of like the R wave here. Slurring of the S wave there. It does look like the PR interval slants down a little bit. I really only see it in this lead actually. There, but it looks like it starts here. So it's hard to know what the true baseline is. And maybe there's not any PR depression, but the P waves are definitely small. And they're actually, yeah, they're small everywhere. And there seems to be some sort of like, the J point's a little bit elevated in most leads, an acceptable amount. It's not excessive. Here, it's coved there with a little bit of a T wave inversion in lead AVL. That's a little bit abnormal. This T wave actually looks kind of bulky, to be honest with you. It's wide. It's not tall though, but it is kind of wide compared with how big that is. It looks like there might be some benign early repolarization. Why the P wave is so small, I don't really know. Huh. Well, I don't really know what else to say about it. It doesn't look like there's any egregious electrolyte abnormality. I mean, but the PR interval is kind of short. The R wave is slurred into the ST segment. So the QT interval might be slightly shortened. Huh. Yeah. All right, let's read. 38-year-old man on the surgical service, pre-admission ECG. Posterior lateral MI. Well, I don't see how it would be a posterior MI. There's no ST depression in leads V1 through V4. There is an isolated Q inversion here, but we talked about that being a normal variant. We did mention right ventricular hypertrophy. Wolff-Parkinson White, I don't see any delta waves. It'd be slurred on this side, not this side. Normal variant, it could just be benign early repolarization, and it might be calling that a normal variant. Right bottom branch block? No, it ends with an S wave, terminal S wave. So this is left morphology, but it doesn't meet the criteria by voltage either. So it's not this, not this. It could be right ventricular hypertrophy, but I'm going to say it's a normal variant. There is left and right ventricular hypertrophy, it looks like to me. But I mean, I don't know. Normal variant. Normal, I don't think normal leads in V1 have an R prime, or sorry, have a big tall R wave like that. But there is no bottom branch block. So maybe it's just a normal variant. Huh. Well, it's either this or it's right ventricular hypertrophy. Given that the QRS is never egregiously wide, and there is an R wave, it'd be wide, but there's no there's no other indication that the right side of the ventricle is. I don't know. It's either that or it's right ventricular hypertrophy, but the right ventricular hypertrophy doesn't make. What else would make it be right ventricular hypertrophy other than this RS complex here? But it also seemed like these are huge. It seems like LVH criteria is met. So I don't know if I would be skeptical to call LVH a normal variant unless it's well, he is young. Yeah, let's just say it's a normal variant. And our backup is right ventricular hypertrophy because there are some characteristics that kind of fit that criteria. Wolff-Parkinson White? Whoa. Very subtle if we missed it. We sure did. I don't see it. I mean, it looked like it's slurred to the right. Whoa. Okay. Well, if it's slurred to the right, then I guess the question is, why is the accessory pathway happening late in the ventricular depolarization. Whoa. Short PR interval, we did see that, but I didn't see a delta wave. Best seen in lead V4. Oh yeah. Very subtle. Missed it. Crap. Slurring of the initial QRS. So we do know it's slurred. A tall R wave in V1 and a negative in AVL. Oh yeah. Huh. Compatible with a lateral bypass tract. Yeah, I guess. What is the differential diagnosis of a tall R wave? Well, normal variant, especially in children, but some adults. Lead misplacement. Yep. Altered chest mediastinum configuration with a heart in a more rightward orientation. Okay. Posterior MI. Yeah, because I guess like a posterior, an R wave in the anterior section is the posterior equivalent of a Q wave. So that could be true. Right ventricular hypertrophy, it just didn't seem like the axis was towards the right. That's why I was skeptical to call it right axis. Sorry, right ventricular hypertrophy. There's no right axis deviation. WPW with a posterior or lateral bypass tract, right ventricular conduction abnormality. That could be true. Hypertrophic cardiomyopathy with or without obstruction. Duchenne muscular dystrophy. I still don't look that up. I still have to. Due to posterior basal fibrosis. One way of testing this hypothesis is this WPW variant would be to increase vagal tone. Oh yeah, during the Valsalva maneuver. It should slow the conduction down at the AV node, accentuating contribution of the bypass tract and making the WPW pattern more apparent. Well, that's neat. That's really cool. I wonder if you could do that with like putting somebody's head in ice. Cool. Okay. Man, that was subtle. Oof, I missed it. All right, moving on. 4 stars. Zoomable image. Looks pretty weird. Abnormal. That's a big T wave. That's a big T wave. Oh, that's a big T wave. And there's ST depression. This is a STEMI. Okay, it's abnormal. The rate is okay. It's like less than 75. I'm sorry, like less than 100, but greater than 75. There's atrial activity. It seems consistent. QRS seems a little bit wide, but not egregious. There's delayed R wave transition. There's an indeterminate axis, maybe slightly leftward. There's elevation in hyperacute T waves in 2, 3 AVF. There's a Q wave in lead 3. And disproportionately big T waves given the size of it. That's what I'm talking about, proportionality. This, according to the J point, might not even meet STEMI criteria, but with how tiny that QRS complex is, I think it's STEMI, inferior MI. There's reciprocal ST changes here. A little bit of ST depression there. Yep. Let's see if there's ST depression in the lateral section. Oh, there's not. It's a little bit of elevation, normal amount. Okay. Inferior STEMI, maybe extending a little bit to the posterior part of the heart because there is some ST depression here. So flattened T waves. Late precordial transition, but only by a little bit. Not a lot. It's not excessive. PR interval's fine. The P wave actually looks kind of big. Maybe there's some atrial disease underlying. All right, posterior STEMI. I'm sorry, inferior STEMI. Why was that 4 stars? Lateral subcardiomyopathy, both inferior, maybe touch of posterior STEMI equivalent. I think it's just a STEMI. See those leftward axis, right? Oh, this is a perfect example. The axis is bent this way. So we're taking our flashlight away from lead 3. If we could somehow externally manipulate this and point the axis that way, wouldn't the ST elevation look a lot bigger? Yeah, it would. Perfect example. Textbook perfect. Remember this. Perfect example. That would look huge in the inferior section if you could point the axis from slightly leftward. back to normal. Awesome. Awesome example. I don't agree. It's not lateral. There are subtle but real ST elevations inferiorly in V5 and V6. Very lesser extent. And very slight ST depression in V2. We saw that. Cardiac catheterization showed posterior basal hypokinesis, and you wonder what circumflex obtuse marginal. Whoa, this person has the wraparound circulation. Huh. Circumflex is on the left side. After ruling in for a small MI. ST depression here in AVL are reciprocal to the primary ST elevation inferiorly and laterally. Huh. Slight ST depression in lead V2 may be reciprocal, lateral or posterior involvement. Whenever you see ST depressions, always look in contralateral leads for ST elevations. Remember that you do not get reciprocal ST elevations with acute ischemia. Extra leads V7 through V9 may be useful in some cases to help review lateral and posterior movement. Yeah, it looks more concentrated in the inferior section. This person must have either a right coronary artery that like comes around and goes like that, but he said circumflex. So the circumflex must come around like that, touch a portion of the posterior section and hit the inferior. What is it, like 10 to 20% of patients have was it wraparound left circ coronary artery? A variation of the coronary artery anatomy, most commonly of the left anterior descending, wrapping around the cardiac apex to supply the part of the inferior wall. Yep. However, the phrase can also refer to a similar variant of the left circumflex, which wraps around the left atrioventricular groove to supply the lateral and posterior walls of the left ventricle. Huh. Well, that's what it was talking about for sure. But why is all of the ST elevation shown in the inferior sections? That's where it's the worst. Okay. That's a little bizarre. I think we got it. Doesn't matter. We activated the cath lab. Yes, we did. Okay, let's continue. Cover up our answers. 3 stars. 3 stars. 3. 5 stars? Whoa. Is that real? 5 stars? Whoa. All right. Let's hash it out. Well, it looks abnormal. There looks to be ST, T-wave abnormalities. The rate appears to be okay. It does look sinus in nature. Interval speaking, the PR interval looks okay. The QRS complex looks slurred to the right and slightly widened. A little bit of notching. Q wave. Huge Q wave. Q wave. Whoa. Look at how high up the S wave is. Okay, you know what? You know what? You might be tempted to think with how much ST elevation there is that this might be benign early repole. However, I don't think there's a little bit of PR depression here, slanted downward. So maybe the ST elevation isn't quite that bad. Look, here's the thing. Benign early repole, that's great. Like this does kind of look like that. This does, this does, this. No, actually those don't, but this does. This and this look like benign early repole. This and this look like benign early repole. T-wave inversion, deep T-wave inversion, and big T-waves compared to the QRS complex. They're almost as tall as it is. Same thing here. Okay. Assuming the leads were placed correctly on this patient, which AVR is normal and the axis is relatively normal, so I'm going to assume that it is, and the R wave does transition. So I think the leads were placed correctly. Flat T-wave, flat and T-wave, flat T-wave. This is hyperacute almost. That still looks pretty broad and bulky. Okay, here's the thing though. This here, I'm going to my paint, should look like this. Okay, the S wave right here is drawn upward. This is called obliteration of the S wave, which is also known as QRS distortion. QRS distortion is caused from injury bringing up the J point and raising it up so fast that you actually see a delayed. It doesn't look like the R wave is transitioning. It pulls it up. It looks like it's transitioned early. So in the presence of Q waves, inferiorly localized T wave inversion and deep T waves there. So disproportionately large T wave in lead 3. And elevation, this elevation looks like benign early repull. This elevation is flat and looks pathologic. So what looks to be pathologic elevation in V4 through V5 may be normal ST elevation in the setting of pericarditis and or benign early repolarization, but that S wave is gone. Yeah, I think this is a left main or LAD occlusion. And this patient's heart is messed up. I would determine these to be reciprocal changes. Why is there ST elevation in the lateral section too? Here, this part looks benign early repolarish. So I think this patient either has multiple occlusions, needs a cabbage, horrible left main coronary artery disease, a big vessel in the anterior segment of the heart, and it is possible that they have early repolarization or something like pericarditis on top of an active MI. That's what I think this is, but I'm very, very concerned with how the S wave comes up here. And I'm very concerned with how big and inverted the T wave is here. This is almost a reperfusion injury pattern here, mainly in these two leads here for sure. I'm less concerned about the ST elevation here because it does look like the J point is like this benign early repull pattern. And the axes are kind of normal. But I'm very concerned about this. This right here by itself. All right, this is STEMI. Double ECG trafters. Oh, after coronary artery bypass graft. Well, that's tough. That throws a wrench in it. 5 stars. I've never seen that. I wonder if that's a typo. Double ECG troubles? Double ECG troubles, I'm going to say it's an acute on chronic, not acute on chronic STEMI. But this looks reperfusion. This looks pericarditis or benign or the repulsish. There may be, now that I know that the patient has coronary bypass graft, it could very well be that there's a residual EKG abnormality depending on how recently this is. Also, there's cardiac remodeling, there's collateral circulation, and then there's differences in the way that the electricity travels through the heart, given the amount of heart that's affected from bypass graft, right? If you need a bypass graft, a lot of your heart's affected. If a lot of your heart is affected, chances are the parts where the electricity runs through as the primary tract were affected. All right, we're going to say either benign or the repull slash sometimes you can have like a left ventricular aneurysm, a persistent ST elevation in V2, V3. There could be an aneurysm of one of the ventricles. But we're going to say benign or the repull slash pericarditis, but we're going to call this an acute anterior STEMI. Yeah. Maybe even anterior lateral. Backup guess? Ventricular aneurysm slash persistent ST elevation. But I think this is an acute MI. The S wave is obliterated. Show answer. The ECG shows a sinus rhythm with the normal QRS axis and intervals. We do know that. The two notable findings are inferior Q waves. Yep, we definitely saw those. Huge Q waves here. Of indeterminate age, and 2 diffuse ST elevations in the anterior and lateral leads with PR deviations. Up and oh, I didn't notice that. Down. Well, we did notice the downward trend, especially here. Consistent with acute pericarditis. The history of that patient with the prior MI with ECG evidence of pericarditis post-coronary artery bypass graft surgery. Kudos to anyone in training who got this right the first time. You're a wave maven superstar and hopefully en route to cardiology fellowship. Okay. Yeah. Yep. So we get a half right. 5 stars. That's interesting. So we did talk about how coronary artery bypass graft can lead. You can have persistent ST elevation, you can have persistent changes, and just residual abnormalities of the EKG. And it did look like there's ST elevation that was either consistent with benign artery repole, but this doesn't seem like a young, healthy, athletic person. This is an older, middle-aged person with coronary artery disease. So pericarditis was definitely on the, what did we say? I think I said pericarditis with an acute MI. Oh, I said benign artery repole. Yeah. That's okay. That's okay. That is concerning though. Man, I wish there was more context. Hopefully they did an echo on this person to make sure that his walls were working the same way. Yep. Okay, let's do one more. Because what are we at? 41 minutes. All right. Covering it up. 3 stars. 3, 2, 4 stars. Zoomable image. Last one. Whoa, that looks abnormal. Oh, what's that notching? Okay, that's what we're going to focus on this one. All right. Normal. Sorry, abnormal appearing. Pretty slow. Wide. The T wave is always in the opposite direction of the QRS. That is good because then you start getting into concordance in terms of scarbosa. Concordance with ST elevation and the T wave going in the same direction, or ST depression and T wave inversion going in the same direction is bad. There you are, QRS. This looks like a ventricular rhythm. Oh, we see some notching. Why is there notching right there? Let's track it down. I don't really see any atrial activity here, though. Well, there does look like there's something there, and something there, and something there, and something there. Yeah, there's definitely P waves. Oh yeah, there's definitely P waves. That's a prolonged PR interval. But what is with that notching? I wonder if this is like a fast atrial rhythm with a ventricular rhythm on top of it. I would be suspicious of electrolyte problems or complete heart block. Yeah, that looks weird. Looks like the atrial rhythm's fast. 1, 2. Assuming this is an atrial rhythm or a P wave. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20 times 6. An atrial rate of 120? That's kind of fast. Or 60 beats a minute. Idioventricular, perhaps? The R wave does transition, although it's late. And there is left axis deviation, not right axis or extreme axis. And AVR is primarily pointed down in terms of its QRS complex. Huh. Interesting. PR segment's good. The T waves are not abnormally tall or deep. Huh. Well, this kind of just looks like a slow and wide rhythm. I don't know what else to be. AV node dissociation, perhaps. Why you see this notching here so well and not here is beyond me. It's there though. Why isn't it in V1, but it's in V2 through V3? And looks like it's there too. I don't know, it just looks like the P waves are not really coinciding with the QRS complexes that well. Some sort of complete heart block. I don't know. Let's see. 71-year-old routine ECG, border sinus tachycardia with a 2-to-1 AV block and left bundle branch block. Oh, it could be that. Yeah, 2-to-1 AV block. So because it looks like I did say that those are P waves at about 120. That's really fast. And if you have a 2-to-1 AV block, then you would get exactly half. 60. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Oh yeah. It's not a sinus rhythm with a left bundle branch block. Acute STEMI, I don't see that. Interior, no. This is too big. It's not excessive. Atrial flutter with a left bundle branch block, I don't see any flutter waves. Sinus rhythm with a right bundle branch block, absolutely not. So we for sure know it's not that. I don't see any flutter waves. I don't see any excessive ST elevation. Sinus rhythm with left bundle branch block, there's more to it than that. I think it's this. I think it's a borderline sinus tachycardia with a 2-to-1 AV block. Yeah, because we're only seeing half of them, and an AV block does explain the wideness. So does the left bundle branch block. Let's say A. Backup answer is B, but I think it's A. Yep, actually, we got that pretty quick. Left bundle branch block in actuality shows sinus tachycardia at about 120 with a 2-to-1. Hidden P waves and the T waves. Yeah, we saw them right there, right there. Yeah, they're everywhere. Very good thing for these leads. Otherwise, I wouldn't have picked it up as quickly. Oh, yep, see, V2 and V3, and left bundle branch block. This most likely is a type 2 infernodal block given the occurrence of sinus tachycardia in the presence of a left bundle branch block. Yep. Patient was referred for elevation for pacemaker. Meet the halfway rule. Always look halfway between the obvious P for hidden Ps. Oh yeah, look at that. So if this is the P wave here, and this is the P wave here, you check halfway, ka-chow, you get those. Note also that in the presence of left bundle branch block, the slow RA progression is non-diagnostic, and some degree of J point elevation is typically seen in the right chest leads with a wide QRS and left bundle branch block that may simulate ischemia. Left bundle branch blocks may both mask or mimic ischemia MI. That's why we use Scarbosa rules. We've hit that a few times. Maybe because it's important. Let's do one more. 4 stars. Good chat. Okay. Well, this doesn't look horribly abnormal upon first glance. The rate's a little slow. There's Q waves. 300, 150, 175, 60, right around 60. 60 beats a minute. Looks pretty regular. It's sinus. The PR intervals, a little long, a little on the high side, right at about 200. QRS, not wide. 2 waves, flat. Smaller than you would think. Smaller than you would think. Whoa, look at this. The J point is really, really close to, it's really far over to the left. I wonder what the QT interval is. Q wave, inferior disease. RA transition, pretty normal, and the axis is normal. This is sinus rhythm. Yep. A little bit artifact. Small T waves. Small T waves and a shortened QT. I wonder if we're getting into calcium issues here. Yes. A little bit of ST elevation there. Not egregious. Although I don't really like the morphology of that. It's sharp. Well, short QT with Q waves. Some ST depression here and here. Trace ST depression. Is this just short QT syndrome? Well, the rate is kind of slow. The PR interval is slightly prolonged. I don't think it would be short QT syndrome. Maybe though. What if calcium is the problem? When I see like the hyperacute T waves, that's potassium. Flat T waves, that's potassium. Hypokalemia. But when you start getting a prolonged PR interval and like the J point comes in here, so your QT shortens, I start to think that there's a calcium issue. Let's see. Oh, Brugadas. No, I don't really think so. Normal variant, early repull. Yeah, it could be that. I don't think it's a STEMI. Brugadas has more marked like T wave would look like that. I don't think it's acute pericarditis. Oh, there might be a little bit of PR depression here. Yeah. I don't know. Early repolarization. Is that really 4 stars? I wonder what the problem is. It's either that or it's acute pericarditis. Whoa. Missed that one. Acute lateral wall STEMI? What the fuck? Excuse my name. I don't know. I mean, the T wave does look a little big compared to the QRS complex. PR is prolonged. We saw that. SC segment elevation V4, V5. It doesn't seem egregious to me. I don't know if I agree with this one. Subtle ST straightening with minimal ST depression. So we did talk about the morphology of the T waves, how it kind of looks like. I don't like the T wave. I did not like that. Huh. Inferior Q waves are borderline. Yeah, but we saw that. Raising question for prior or concurrent inferior YMI. Occluded left circ. Huh. Normal variant early repolarization is the differential. This is not likely because the changes in V5, V6 mainly, not the mid-chest leads. There are reciprocal appearing ST depressions in V2, V3. Yeah. You know, I saw that too. ST depression in the precordial section is never normal. The latter finding also excludes acute pericarditis. Focal myocarditis, of course, could look exactly like an MI, but it is rare, and it's not one of the choices. Brugada's pattern is related to distinct right precordial ST elevation with the right bundle branch block appearing morphology. Yeah, it kind of goes up and then down like that. Well, you know, 41. See, this is why I think I might have chosen something different if I would have understood that the patient had chest pain or recurrent chest pain. That is subtle. That's one of the most subtle STEMIs I've ever seen. Or am I? Maybe not ever, but that is very subtle. I didn't like the Q waves. I didn't like the T wave flattening. We saw the elevation. We did see the ST depression. I didn't like that. And I also don't like the appearance of this T wave shooting sharply up. It just kind of seemed like a normal variant to me. Okay. Well, I missed one. We had somebody die. Yes, we did. Of course, patients with chest pain should obviously always be treated more ominously than patients without chest pain. In general, as a general rule. Never saying non-chest pain free patients can't have MIs, and remember saying that all chest pain patients are MIs. All right. I'm getting tired. I don't mind going off on a bad note. That's okay, unless this next one's really interesting. 4 stars. No. I don't know what that is. Some weird notching. Yeah, I don't feel like doing this one. Let's do this one tomorrow. Okay, see ya.